This is TTT Live. I am DK Rasta. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Talk City 91.1 FM, and on Facebook at TTT Live Online. We go now to the Senior Corporate Communications Officer at the Ministry of Health, Al Alexander.
Good morning and welcome to the Ministry of Health's virtual media conference for Monday, June 28, 2021, where we aim to provide you with clear and accurate information on COVID-19. Our panelists today are Dr. Avery Hines, Technical Director, Epidemiology Division, Ministry of Health, and Dr. Adesh Surju Singh, Director in the Directorate of Women's Health, Ministry of Health. I am Al Alexander, Senior Corporate Communications Officer at the Ministry of Health, and I will moderate this morning's media conference. I now hand you over to Dr. Avery Hines, who will present the latest clinical, vaccination, and epidemiological updates. Dr. Hines.
Thank you, Mr. Alexander. Good morning to my colleague, Dr. Surju Singh. Good morning to members of the media, members of the viewing and listening public. If you may have the first slide, I'll go straight into the clinical update. Next slide, please. That's the last one. First slide. The clinical update being as follows. As at June 27th, 2021 at 4 p.m., at both public and private facilities, we had tested 226,180 individuals. Of these, 32,198 tests returned as positive, and we had 23,873 of those individuals recover to date. To date, there have been 817 deaths, and we extend our condolences to the members of the bereaved families. And at present, we have 7,508 total active positive cases, and those cases are distributed as follows. There are currently 401 individuals hospitalized, 6,827 individuals in home self-isolation, and 151 individuals in step-down facilities. In state and state-supervised quarantine facilities, we currently have 305 persons. At this time, the hospital occupancy overall stands at 52%, with 48% ward occupancy, 76% ICU, and 93% HDU occupancy. Total vaccinations delivered to date, persons vaccinated with their first dose stand at 204,249, and those fully vaccinated stand at 71,426. There have been, as at yesterday, 129 new positive cases identified from samples that range from dates from the 23rd to the 26th of June. Going directly into the rest of the epidemiological update, if we look at the epidemic curve, we see to the left the grey bars representing July to December 2020, and the bars from the middle of the graph moving to the right representing January through June. The gold bars, the tallest ones, represent the cases as identified by date of swab in the month of May. Those blue ones to the right, which are shorter bars, represent the cases by date of swab for the month of June. And we see that overall, with the dotted line representing that rolling average, we are seeing a continued slow but steady downward trend. Let's go to the next slide. We're looking at that same data now aggregated by week. And what we are paying attention to most here is two things. Number one, the percentage change from one week to the next, looking at the change between week 24, which is week before last, and week 25, which is the week last completed. And that change is about 25%. We've gone down from the week before's total to last week's total being a 25% drop. And we're seeing now that final bar being the number of cases so far for the start of week 26, which began yesterday. The orange section behind this is the section that represents the percentage positivity, meaning out of every 100 samples, how many came back positive for COVID. And at present, we do see that there is, for the week of week 26, which is basically just yesterday's data, a slightly higher positivity than in the weeks gone, but we will look at that trend throughout the week to see if that continues to manifest or if this particular group of samples was really just a high probability or a high risk group that happened to have been tested and that happened to have the results come through today. But the positivity today, or to date for this week, stands around the high 30s, whereas previously it was around 31% for weeks 24 and week 25. Next slide, please. That same data is now aggregated in this graph into months. You see the monthly total for basically almost the end of June, now standing far lower than the total for May, showing that downward decrease. And we do see that the approximate or the average positivity for the entire month stands around 32%, and that's down from the high of about 43% that we saw in the month of May. Next slide, please. Looking at the demographics, that is the age and the sex distribution of the positives, we see that we have basically 50-50, 50% men, 50% women, just about, and that the majority of the cases still fall in that mobile working age group of 25 to 49. Next slide, please. And among the fatalities, we notice that those fall into the older age groups largely, the majority being in the above 60 age group. We do see that there is an increase in the proportion of the women over 85 that we've been seeing in more recent times, and that is to some extent influenced by the infiltration of virus into some of the elder care facilities. That's a situation that's currently being worked on, but that situation, as an international experience, has resulted in some higher rates of fatality among that older and more vulnerable age group. The balance of males to females among the deaths stands at about 60% men, and that's down from 75% earlier on in the epidemic. And that brings me to the end of my epidemiologic update. I'm going to turn you over to Al for the remainder of the updates.
Thank you very much, Dr. Hines. We now go to Dr. Sergio Singh, who will provide an update on the COVID-19 vaccine and the ability of women to breastfeed. Dr. Sergio Singh.
Thank you, Mr. Alexander. Good morning to my colleague, Dr. Hines. Good morning to the members of the media and, of course, the viewing and listening public. So I represent the Directorate of Women's Health, and our responsibility at the Ministry of Health is to improve the health care delivered to our mothers and newborn babies in Trinidad and Tobago. I'll be giving an update on the performance of the maternity services, as well as some issues related to pregnancy and breastfeeding and COVID-19. So I have a few slides. I'd like to have the first slide, please. So this graph here, I'll describe it a bit for those who are listening. It's a graph that represents the monthly births in Trinidad and Tobago. We have 3 completed years, 2018, 2019, and 2020. And we have 1 incomplete line, which represents the number of deliveries up to the month of May 2021. In this graph, which is plotted by month, you can see a trend where somewhere around August to September of every year, we have a slight increase in the number of births being delivered at our nation's hospitals, and this represents both the public and private sector, of which 91% of these deliveries are actually in the public sector, with 9% in the private sector. So this is a seasonal trend that we see, and we collect this data in order to improve how we staff our nation's hospitals, to ensure that there's enough staffing in those so-called peak seasons. Interestingly, there's the third line, which goes all the way, this is the green line on the screen, is for last year, and we actually saw that trend still continue despite not having a carnival last year, which is an interesting note that we are looking at. The lowermost line on this graph shows that the number of births have actually decreased yet again. It's every year we are seeing this trend, COVID or no COVID, and this is something we are taking note of. So in fact, despite the issues with COVID, we haven't seen any increased numbers of deliveries in Trinidad and Tobago. Can I have the next slide, please? So as regards our maternity and newborn services, I want to say that we have continued to offer all our services. These are critical emergency services in a safe environment across all of the regional health authorities. We have established special areas for COVID-19 positive women, and those who have emergencies or those who need to be delivered. I want to reassure the public, and I want to encourage all our pregnant women to attend your clinic visits. We are seeing some fall off in this. All routine in-person care, all support continues. We have also established a telemedicine service for our quarantine patients. If you have COVID-19 and you're at home, we will reach out to you. I also want to make a special note for those who have delivered. We have postnatal clinics and well baby checkups. We need all our babies to continue the mandatory vaccination program that we have against all of those diseases. Next slide, please. So in terms of our report, to date, in our database, we have, since the start of the pandemic, 170 pregnant women who have now contracted COVID-19. They have been at various stages of pregnancy, and not all have been delivered. I was actually last here in March of this year, and at that time we had 41 cases. So just like the rest of Trinidad and Tobago, we have seen a surge in the pregnant clientele. Next slide, please. There are some higher risk situations. Now, pregnancy is by itself now considered a higher risk condition if you contract COVID-19. But there are another group of women, if you're over the age of 35 years of age, if you have diabetes, high blood pressure, obesity, asthma, or if you are in the second half of pregnancy, if you contract COVID-19, you are more likely to get seriously ill. Our data shows as well that of those 170 women, there were at least 10 women who ended up in the intensive care unit. Can I have the last slide now? So this slide tells us a bit of the effect of the virus on pregnancy. We so far have not seen any direct fetal effect on the baby as a result of the virus. This is good news. There are no abnormalities or any of these things that we have seen. We have, however, seen an increased risk of preterm delivery. As I said before, you have an increased risk of hospitalization, and there's also a possible heart complication that we are seeing in pregnancy. If you contract COVID at this time, we are reassuring you you can safely breastfeed with the guidance of the healthcare professionals. I'll now move on to some information which has been updated with respect to vaccines and pregnancy and our breastfeeding population. So lab studies for all of the WHO approved vaccines show no direct effect on the developing fetus for the lab animals that were studied. So they seem to be quite safe in the laboratory. The initial studies did not include pregnant or breastfeeding women, but these studies are now ongoing. Based on other similar vaccines in pregnancy and the technology in the background, the approvals given by WHO for emergency use in pregnancy and in breastfeeding, you'll see on their site that some of this is allowed. Additionally, some countries also allow emergency use through their own country's approval mechanisms. We have some new news. This is really as a result of the National Immunization Technical Advisory Group, which is a group of experts which is chaired by the Chief Medical Officer. So they've completed their deliberations, and as of yesterday, a formal decision was made with respect to breastfeeding and the approvals. After considering all of the documentation, we have now allowing, as of officially today, to roll out the use of the Sinopharm vaccine for the breastfeeding population. The approval does not cover the AstraZeneca vaccine based on the information before the committee. For the general population, I am asking you, if it's your turn and you're eligible for vaccination, please make sure you avail yourself, especially if you're a young pregnant woman. We want to create a barrier between the virus and those pregnant women. Continue to follow all public health measures, and I thank you very much. I look forward to the questions.
Thank you, Dr. Sijit Singh. Certainly some great news for our breastfeeding mothers. As we move into our question and answer segment, our media representatives are asked to pose their questions to members of the panel and state their name and media house. We are kindly requesting a maximum of 2 questions per media house. We begin with CL Communications.
Good morning, Natalie Singh, Caribbean Lifestyle Communications. I was just wondering, is the Delta variant present in Trinidad, and how worrying is it should that variant hit Trinidad? And then my second question is, I am looking at the statistics for COVID-19 deaths, and I was just wondering if there was ever an instance when someone died because no one was around to change their oxygen tank. Thank you.
Okay, thank you for the questions. At this time, with the sequencing that has been performed, there is no evidence of Delta variant in any of the samples that we have so far sequenced. There is constant monitoring for the introduction of variants, and if that changes, that will most certainly be announced. With respect to the second question, that is not a question which I have information for. The operational aspects of each individual case would probably best be addressed, or questions about those would best be addressed at the clinical level or the RHA level.
Thank you, Dr. Hines. We now move to AZP.
Hi, good morning, Priya Bihari, azpnews.com. My first question is for Dr. Hines. I don't know if you may be able to have the information now, but can you give us an idea how many people who have passed away have had a vaccine, either first dose and or second dose? I don't know, you may get at least for this year. And my second question is for Dr. Surjit Singh. Dr. Surjit Singh, you said some of the pregnant women who had contracted the COVID-19, not all of them delivered their babies. Can you say how many did not, and was that a result of COVID-19? Thank you.
Okay, thank you for your question. We are actually still compiling and comparing and validating the vaccination information. There have not been many cases where a vaccine was reported to have been on board or have been delivered in the event of a death. In those where it has happened, there are maybe about 4 or 5 that we have on record, and they're usually persons who would have contracted illness pretty soon after having had their vaccine, but we're still attempting to get the documentation on the vaccine itself from some of these individuals. So that's something that will be refined and clarified as that information becomes available. It's not always presented to the clinical staff at the point in time when the fatality may occur. But so far what we've seen of the ones that have been reported by mouth, verbally, that is the ones that would have had a fatal outcome and claimed to or said that they have a record of a vaccine, those persons have all only had their first dose of vaccine, and it would have been relatively close, less than 2 weeks after that first dose, that they would have then become ill. And that is sort of in keeping with the expectation that your first dose of vaccine still needs a couple weeks before your immunity is boosted sufficiently by it. And even with that first dose of vaccine on board, the immunity is not optimized yet, which is why your second dose of vaccine is of utmost importance. If you've had that first dose, you need to have the second dose in order to optimize, to get the most out of your vaccination, both in terms of the strength of your immune response and the duration, meaning how long that immune response will last. So we want to ensure that people continue to vaccinate, continue to go for both of their shots, and also, even after you're vaccinated, we do want to continue to encourage you to have that public health awareness of the ongoing requirements for mask wearing, physical distancing, hand hygiene.
Thank you.
Okay, and yes, thank you, Priya, for the question. So, whether you're asking about data related to the outcomes of the pregnancy, as you would appreciate, of course, pregnancy is a certain duration of time. So there are a number of ongoing pregnancies with respect to women who have not delivered as yet. In terms of excess outcomes, in terms of miscarriages and so, we are getting the information whether if this is happening, but from international publications, we have not seen any effects as such from COVID and pregnancy. I hope that answers your question.
Thank you very much, Dr. Sergio Singh. We now go to Guardian Media to field your first two questions.
Hi, morning, everyone. Rashad Khan, Guardian Media Limited. Okay, so both my questions this morning are for Dr. Sergio Singh. Dr. Sergio Singh, could you say why it is that we've been seeing this decreasing trend in births, as well as probably quantify it, because I couldn't see the exact figures that were on the graph? And my second question, so the Sinopharm for breastfeeding mothers, is any other considerations being given perhaps for AstraZeneca or even it's being deliberated for pregnant women as well? Any other further deliberations like that being undertaken at this time?
Okay, thank you, Richard. Excellent questions as always. So with respect to the graph, which you couldn't see clearly, so I've actually been in this post for just a couple of years. So I've been collecting, our unit has been collecting for the first time from both the public and private sector. So I only have so-called accurate data for the last couple of years to compare with. The rest of data came accurately from, of course, the CSO. In the 1980s or so, we had 25,000 deliveries. In the 1990s, it was started to fall 20,000 and so. So it's a trend that's continued. In the last few years, we hovered just around 16,000 to 17,000. And actually last year, we dipped below 16,000. So that's the sort of decline we are seeing. And this year, we are again seeing a decline. There are many factors which affect, how many babies are being born. But we think we now have much more family planning being practiced. Persons are waiting a little later in life to have their babies. They're having less babies. The average family has a number is called 1.6 now, instead of having 2 babies. So when you look at the numbers, so we are seeing this decline. There's of course education of our women as they go, and they are leaving the families for later as well. So there are a number of factors. The second question has to do with vaccine considerations. So just not to confuse matters, there are hundreds of vaccines in development and different stages of approval. It's very early days yet. So, of course, any new vaccines, any data as it comes to hand, we have these committees that will look at the information and provide updates. And it's very promising for some of them. They're actually researching the mRNA types of vaccines right now in pregnancy and breastfeeding women. So we are hopeful that we'll get some sort of full approval as time comes along. So that's hopefully answers those two questions. Thank you.
Thank you very much, Dr. Sergio Singh. We now go to TV6.
Hi, good morning. Alicia Boucher from TV6 here. My first question is for Dr. Sergio Singh. Dr. Sergio Singh, I was wondering, you said that the data before the committee made them determine that they would use the Sinopharm for breastfeeding women, not the AstraZeneca. And I'm wondering if you could delve a little bit deeper into that for me as to what factors surrounding Sinopharm and not AstraZeneca were deemed safe for breastfeeding when compared to AstraZeneca. So that's my first question. My second question is for Dr. Hines. Dr. Hines, I know that there was a projection in terms of where we would have been, an epidemiological projection as to where we would have been had we not taken the measures that we took in terms of, let's say, the shutting down of beaches, the state of emergency. And I was wondering if we had done a projection as to where we should have been with those measures being implemented, and if so, whether we are on target, whether we are below targets. Thank you.
Okay, I'll take the first question. Thank you, Ms. Boucher. So, well, of course, I would have submitted information on behalf of the Directorate of Women's Health to the National Immunization Technical Advisory Group, and they would have considered the information we provided. I was not, of course, present at the deliberations, but I want to reassure the public first and foremost, regardless for the general population, regardless of what vaccine is presented to you, it is far safer to take the vaccine to avoid the issues related to hospitalization, ending up in a high dependency unit bed, or in the intensive care unit, or worse yet, death. So the vaccines we have are safe for the general population. You will appreciate pregnancy is a specific group where there's a mother and a developing fetus. So in terms of the approval process, it's not as easy as the general population. The data we had a lot more data when it comes to the Sinopharm in terms of the technology being used. It's really a killed form of the original virus, and we have used this technology a lot in the past, including in the development of the influenza vaccines, which we already use in pregnancy. So we did have a lot more leeway when it came to approving it. However, now that the baby is delivered, we even have more leeway because the actual vaccine isn't transmitted in the breast milk to the baby. All that is transmitted, in fact, are good things. The antibodies that mother makes goes in the breast milk and actually gives that baby another level of protection because, as you know, children below the age of 18 aren't allowed to be vaccinated at this time. So coming back to the original question about AstraZeneca, we didn't have as much information to submit to the committee to allow its approval.
Okay, thank you. And for the second question, now that's a very interesting question. What we projected, or the projections you would have seen, would have been those where we looked at if we continue having cases at the rate at which we're having them, if we continue having increases at the rate at which we're having them, where we would have been. It is much more difficult to calculate where you should have been. You can calculate where you'd like to have been, but where you should have been is going to be influenced by a range of things that we can't necessarily predict. One of the things that we noticed is that even with the restrictions, even with the implementation of the several measures aimed at reducing movement, there was still a significant amount of movement within the population. If you look at the decrease in movement for last year, when restrictions were implemented, as compared with this year, you realize that that decrease in movement and the consequent decrease in persons interacting, that decrease was not as significant this year as last year. So the impact, therefore, of reducing that risk of contamination, that risk of transmission, would be somewhat less if you continue to have additional movement. Very difficult to say what should have been. So we didn't have a benchmark that we expected to reach, but what we did is we continued to monitor the change. And as the change became a decrease as opposed to an increase, a new projection was made looking at how quickly we expect to continue to decrease. And that was something that would have been presented at the Prime Minister's press conference on Saturday. So not a should have been, because it's very difficult to predict a lot of the variables in there. But what we're looking at is how we are performing with respect to previous rates. So we can see with our projections whether we continue to decrease at the same rate, if the decrease is faster, if we aren't decreasing as quickly anymore. Those are the things that our projections actually allow us to do at this point in time.
Thank you for your question, Ms. Boucher. We now move to I-95 for your questions.
Good morning to you, Al. Good morning to everyone on the panel. Whitfield Turner from I-95.5. Dr. Hines, I am hoping you could give me some assistance here. Now, you would be aware by now that it was reported that Canada and some other countries are not recognizing the Sinopharm vaccine as a vaccine accepted for entry by fully vaccinated persons. Now, notwithstanding a country's right to set their own criteria for entry, under these circumstances, what advice would you give to someone from this country who has already been fully vaccinated using Sinopharm and need to travel to Canada or any of the other countries which do not now recognize Sinopharm? That's question one. Question two, a person who travels having gotten their first dose of the vaccine and the appointment for the second dose comes around and they are still outside of the country, what happens under those circumstances? Are they going to be allowed to take that second shot wherever they are, or will they have to wait until they return home? Thank you.
Okay, thanks for the two questions. Your first question raises an issue that I think perhaps isn't well understood. When a country says they don't recognize a particular brand of vaccine as one which they will term a traveler as fully vaccinated if that traveler has that particular vaccine, it doesn't mean that the person cannot travel to the country generally unless the country specifically says so. What it does mean is that instead of being managed as a fully vaccinated individual, they'll be managed as an unvaccinated individual with whatever the attendant requirements for quarantine prior to movement may be. So in the same way that you're seeing that we're looking to move towards a similar system here where vaccinated individuals are treated in one way and those who are not yet vaccinated then have to quarantine, etc. That is what will be expected when you cross a border in a country where your particular kind of vaccine may not be recognized. So it isn't that you're debarred from movement. You just have to factor in the fact that you will maybe have to quarantine for a time period prior to being able to move around. Now, the second question is a little more tricky. It is not necessarily guaranteed that you as an individual from another country will be able to access vaccine in the country of your destination. However, if it is that you have to travel, we prefer or we recommend that you make your arrangements for travel after you've completed your vaccine schedule as opposed to in the midst of it, for the very reason that you don't want to be stuck in a situation where you're not guaranteed to get your second vaccine. However, if a second vaccine of the type that you have already been administered is available in the country to which you have gone, and you can access it, then you're encouraged to do so at the time that you would have, that you would generally have been recommended to do so with your vaccine appointment, and you'd have to have that conversation with the health system in the country where you are. So I'm hoping that helps to clarify.
Thank you very much. We now go to Radio Tambourine.
Yes, good morning. Good morning, Clayton Clark, Radio Tambourine. And I want to follow on that question and response by Dr. Hines, because there are athletes and sporting bodies who are in a little of a bind right now because they have to send athletes out to international meets, and it's a problem now that they have booked tickets and arrangements and really putting a pressure on some of these bodies to negotiate, you know, the new guidelines sent out by the US and Canada with regards to Sinopharm. So I don't know if there's any advice or help that can be offered, because some of them are saying, in addition to that, there's a challenge of booking flights or not booking flights not available to come back in. Right, so my second question is, the whole issue of variants and the names. You know, initially it was the variants were referred to by country. And I just want to ask Dr. Hines if you can just remind us of the new WHO terminology for the variants, because from what they were saying, they didn't want to stigmatize countries by the variants or the other way around. So if you could just remind us of the new naming of the variants for the purpose of education, sir. Thank you.
Sure, no problem. Thank you. I think I'll go with the second question first because it's the easier one. So the first variant that was identified was the one identified in the UK. So they basically gave them names that follow in what we call chronological order, in the order in which they popped up. So the Alpha variant, first letter of the Greek alphabet, is the one that showed up first in the UK, Beta being South Africa, Gamma being what showed up in Brazil, which we call the P1 variant here as well, and then the Delta variant being the one that showed up in India. So it's really in sequence which one popped up first in which country. They just name it according to sequential letters in the Greek alphabet. Now, the first question. The arrangements for sporting meets, etc., and the vaccination requirements and timing, all of those are things that the sporting bodies would be required to check into prior to making bookings, making flights, etc. And I believe that the sporting bodies themselves know how to access the relevant personnel and information to make those bookings. As I said before, if it is that a particular kind of vaccine isn't recognized by a country, then you have to factor the need for quarantine, etc., into your movement, into your plans with respect to when you travel. There isn't really too much that I can say from this end of things with regard to how those arrangements will be made with all the various variables in play, but that is something that the sporting bodies can reach out to the various persons in the health system to provide additional guidance as needed with specific situations.
Thank you, Dr. Hines. We do have some time for a few more questions, so now we will take one brief question at a time. We go to AZP.
Hi, good morning again, and thank you all. I just wanted to find out, in terms of the pregnant women now, are they going to be, bumped up in terms of getting their vaccines? Are they going to bump up on the priority list? What do they do now if they want to get a vaccine? How do they approach it? Thank you.
Okay, Prior. So thank you again for the question. It allows me to keep clarifying the issue. So the approval that we have granted is strictly for the use of the Sinopharm vaccine if you are breastfeeding and you have the opportunity to get vaccinated, if you are in one of those high-risk groups as we roll the vaccines out. So this includes healthcare workers, persons who work in the services, the public services, frontline personnel, manufacturing, and so on as it's rolled out. So if you're breastfeeding and you happen to be in that group, you're allowed to be vaccinated with the Sinopharm vaccine. So just to be clear, we have not allowed the approval at this time for pregnant women. Research is ongoing, more deliberations will take place, and once it's approved for pregnancy, we will inform the general population. Thank you.
Thank you, Dr. Sergio Singh. My apologies to Newsday. We would have we would miss you, so we can ask you two questions. Newsday, good morning.
That's quite all right, Mr. Alexander. Shane Tupperville from the Newsday newspaper here. Two quick questions. Both of them can be answered by Dr. Hines. I just want to go back to the issue of the Delta variant. I know that the CMO and the Prime Minister would have expressed some concern over that particular variant. Just wanted to know what contingency plans or added precautions we have in the parallel healthcare system when the borders are reopened, which they are expected to do shortly. And the second question has to do with getting into contact with the elderly for their vaccination. There's a decent-sized portion of elderly people ages 65 and above who are not registered on either the public or private healthcare systems. Just wanted to know how would the ministry get into contact with them for them to come in and get their vaccines. That's all.
Okay, thank you for the two questions. Now, again, it is really important for people to understand that irrespective of which variant is in circulation, the plans for the recommendations for the strategies for reducing the risk of transmission of the variant remain the same as for any other version of the virus. So the first barrier, the first layer of protection is the fact that individuals wishing to travel would have to have both, at this point, negative PCR and evidence of vaccination. So that in and of itself reduces the probability that someone is coming in with the virus. The other things that remain in place, especially within the parallel healthcare system, are all of the infection prevention and control measures that are implemented to reduce transmission, use of PPE, or the other precautions that currently apply. Because irrespective of what variant is circulating, the manner in which it is transmitted is the same, and that is via droplet or aerosols, and therefore the pre-existing strategies hold. The need for additional adherence and stringent adherence to both the infection prevention and control and the general public health measures, the wearing of the masks, the washing of the hands, the avoiding other individuals if you are ill. The need for those goes up as the risk of transmissibility goes up. But there isn't anything different that would need to be done beyond ensuring that people adhere as much as possible to all of the guidelines that are put in place in order to reduce the risk of transmission. With respect to the over 65s, as additional vaccines become available, additional strategies will be made public for reaching out to those who have not yet been reached. There are several things in play at the same time, including targeting particular high-risk groups, both by age and by other comorbidities. And we will continue to work in tandem with those groups, and we will continue to work in tandem with the health system to identify additional individuals that would need to be covered as more vaccine becomes available. So more detail will be made, will be publicized at the point in time when additional arms of the strategy are implemented.
Thank you, Dr. Hines. We'll take the follow-up question from Guardian Media.
Morning again, everyone. Okay, Dr. Sergio Singh, this is just to clarify because I feel like we are heading down a road for some confusion, right? So this announcement of the approval to use the Sinopharm for breastfeeding mothers, it's not that they are now being counted as a category of persons to be vaccinated. It's just that if you happen to fall within one of those categories of persons being vaccinated and you're breastfeeding, you're going to be able to receive the vaccine. Is that what you're saying, right? I just want to make sure that we're not heading to any misunderstandings.
Yeah, so thank you for allowing me to clarify. Yes, so what I have said is that we have now, on your form, we have a screening form that everyone fills out when you're going for your vaccine. In that form, it asks a question for our females, if you're breastfeeding or if you're currently pregnant. So if you say you are breastfeeding or currently pregnant, you are now said, okay, you're no longer eligible and you are not allowed to take the vaccine. So just to clarify, if you are eligible for the vaccine, that's the first thing, you're already eligible and you happen to be breastfeeding, you are now allowed to take the vaccine. So I hope that's clear, Rishad. Thank you.
Thank you, Dr. Sergio Singh. We now go to TV6 for your follow-up question.
Okay, hi. My question is for Dr. Hines. Dr. Hines, a while ago you said that in terms of the measures that were implemented compared to the time before, you're not seeing that decrease as you would have seen previously. And I was wondering, what is the Ministry of Health attributing this seemingly very slow decrease this time around, despite having arguably more measures in place with a curfew and so on, where you didn't have that in previous lockdowns? What is the Ministry of Health attributing this slow decrease to at this time, or what aspects?
Okay, thanks for the question and for allowing me to clarify. What I said is that we weren't seeing a decrease in movement, i.e., that is population movement, the mobility of the population moving around, interacting, going to various places. That was not decreased to the same extent that it would have been last year when other lockdowns and restrictions had been implemented. And that in and of itself would be one of the drivers of the slower decrease in transmission. The more movement you have, the more mixing you have, then the more slowly your decrease in transmission will occur, because there's a greater probability that the people moving around may be carrying asymptomatic or symptomatic infection and infecting other individuals. So the greater degree of movement is largely attributed to, or largely attributes to the less rapid decrease that we're seeing at this point in time. That's one of the major driving factors. And again, we would like to point out that beyond the mass movement, the individual decisions not to do things like break quarantine, move around when you know you're ill, pretend not to be ill so that you don't have to be quarantined, those things that sometimes you get anecdotes, stories, reports about, all of those things are potential causes for additional clusters where clusters could have been avoided. So we want to again remind people that the public health measures are for everyone's benefit, and that the faster we optimize or get the best out of our adherence to them, the more quickly the rate of cases will come down.
Thank you, Dr. Hines. We quickly move to Radio Tambourine for your follow-up question.
again. Good morning again. My question, this one is from the public. Why can't senior citizens be granted a pass to allow them to access therapy by walking or bathing on the sand of designated beaches, especially those that are doing physical therapy? And they're saying that some of them, the doctors can actually verify that they are in need of such exercise.
Okay, thanks for your question. The simple answer to that is making those sorts of exceptions then opens its own Pandora's box. And what we really need to do at this point is keep the movement to a minimum where it is not absolutely essential, so that we can accelerate the rate of decline of transmission. So this is not the point in time at which we want to move towards allowing additional moving, additional interaction while we're trying to slow this the spread of this pandemic. So at the point in time when that becomes more appropriate, when the epidemiologic situation allows, when cases are at a lower rate, when there's higher levels of vaccination, all of those things put together will help us to get to a point where the therapies that you are currently speaking about will be safer to implement. Until such time, we do want to continue to advise that the existing public health restrictions be observed.
Thank you, Dr. Hines. We now go to the Newsday for your follow-up question. Yes.
Hi, good morning again, everyone. I just wanted to ask a quick question to Dr. Hines. I understand that the Abdala vaccine in Cuba recently reported to have a 92% efficacy. Just wanted to know if, given emergency use approval by the WHO, will the government be looking at sourcing that from Cuba?
Okay, thanks for your question. As I believe has been said before, once a vaccine gets WHO emergency use licensing and approval, then any of those so approved vaccines will be up for consideration, but that is a decision and an announcement that will be given or made at prime ministerial or ministerial level.
Thank you, Dr. Hines. Now, Dr. Sergio Singh, we are certainly happy to have you here as we have a few frequently asked questions from the public that we would like you to address. Persons have asked, now this is not me, Dr. Sergio Singh, do I need to take a pregnancy test before taking the vaccine?
Okay, so good question, Al, and thanks for asking it on behalf of the population. So with respect to pregnancy testing, the WHO, the World Health Organization, has specifically said that we shouldn't really offer pregnancy testing or recommend it prior to taking the vaccine. However, as I said before, if you know you are pregnant, if you are trying to have a baby and you might be pregnant, in that circumstance, that's the only time I would suggest that we take the pregnancy test, and at that point in time, we would not allow you to be vaccinated. So for the general woman who is in the reproductive age group, you don't have to do a pregnancy test before taking the vaccine.
Okay, thanks for that clarification. And again, this is not me, Al Alexander, asking a question, but how soon after taking a vaccine can I try for pregnancy?
Right. Yes. So this would be for couples who are trying to have a baby. I would answer the question this way. So it doesn't affect the males, and it doesn't affect the females in terms of taking the vaccines. In fact, I would encourage you, especially if you're in a high-risk category and you have the chance to take the vaccine, to complete the vaccination schedule before trying to have a baby, and you can proceed as soon as you've completed the whatever vaccine schedule you need to follow.
Okay. All right, so you mentioned it doesn't affect the males and the females. Does it actually affect fertility of both male and female?
So, right. So, Al, that's a good question. In terms of, there's a lot of misinformation out there that's spread through the social media. The vaccine does not affect your fertility. However, the COVID infection may in fact affect fertility. We have seen in some fertility centers that they have had some studies that are showing that the semen analysis, the sperm counts are actually reduced. So there is a chance that the COVID virus may affect the male's fertility.
Okay, great. And if I took one dose of a 2-dose vaccine and then became pregnant in between, should I still go for my second dose?
Okay, so if you find out that you are now pregnant, you now fall into that category. You're pregnant and you will not be offered the vaccine. That's an interesting situation, and I think there would be people who would have one dose of the vaccine, so you'd have some partial level of protection. You're not considered fully vaccinated. At this time, because we're not vaccinating pregnant women, after you've completed the pregnancy, then you can be eligible to take a vaccine. And again, scientific data is continuing to evolve. We'll see what the information is at that time.
Okay. All right. So another person saying, I am worried about the rare risk of blood clots and the AstraZeneca vaccine, and I am on a contraceptive pill. What advice can you offer? And does that person need to take a blood thinner?
Right. So yes. So there's a combination of questions, but it's an important question. Essentially, the AstraZeneca vaccine, as we've said before, has a very rare risk of blood clots associated with it, and we have this information. That's, of course, we know the scientific data suggests the profile may be a slightly younger person and tending towards women. Therefore, we are a little bit more cautious sometimes when it comes to the AstraZeneca vaccine. Having said that, the oral contraceptive pill, as you would also know, has a slight increased risk of blood clots. But this information has also been diluted in the public in terms of the information. The risk of getting a blood clot when you are on the contraceptive pill is very low, but it's more so when you now start the contraceptive pill. That's important information. What I'm asking the public to do is certainly not stop their contraceptive and then try to take the vaccine, because in fact, pregnancy has a greater risk of getting a blood clot than being on the contraceptive pill. So I'm asking you to continue your pill. There's also no need to take a blood thinner before going for your vaccination. I hope that answers those questions, Al. And Al, could I just add one thing, that just to clarify one more time? With respect to we're not adding on like a special category for breastfeeding women to go out there to get vaccinated. We're just saying that if you're eligible for the vaccine, if you fall into those special groups and your turn comes up, breastfeeding is no longer a contraindication to getting vaccinated. So I hope that clears that question up again.
Great. Thank you very much. Ladies and gentlemen, we have come to the end of today's media conference. Thank you for sharing your time with us. Please note the vaccination rollout continues in all RHAs for persons 65 years old and over. And remember, you can only be considered fully immunized after 2 weeks from receiving your second vaccination. And even after you are fully immunized, you will still need to practice the 3 W's to continue to protect yourself and others, which is wash your hands, watch your distance, and wear your mask. And of course, the great news that we got from Dr. Sergio Singh today, breastfeeding mothers can now be vaccinated with the Sinopharm vaccine. Great news. Have a good day, everyone. Be safe, and goodbye for now.
This is TTT. Live for local.